Welcome to this high-yield Step 3 review from Roadmap to Residency. Step 3 rewards the physician who thinks about what to do next in the real world, especially in the outpatient clinic, and who chooses care that is appropriate and cost-effective. Our goal is not to reteach medicine, but to show you the most tested patterns and how to attack the question stems. Work through your question bank alongside this video, because these patterns are best learned by doing questions. Here is what we will cover. First, the highest yield question patterns. Second, what makes Step 3 different from Step 2 CK? Third, quick reference sheets for drug dosing and common protocols. Along the way, we will work practice questions and explain why each choice is right or wrong. This video sharpens how you take the test, so pair it with your question bank to master the content. Let us start with how Step 3 differs from the earlier exam. The first shift is the question itself. Step 2, CK often asks for the diagnosis. Step 3 asks for the next best step in management, so the answer is a decision, not a label. Hunt for the action the question wants, whether a test, a treatment, or a referral. The second shift is the setting. Step 3 lives in the outpatient clinic and rewards long-term management, so watch for prevention, screening, cost, and follow-up. A few more differences are worth knowing. Step 3 runs across 2 testing days. The first leans toward foundational science and diagnosis, the second toward management over time. Cost-effectiveness is woven throughout, so the best answer is proportionate to the patient, not the most aggressive workup. Step 3 also includes interactive patient simulations. In those, you order tests over simulated time, so act first, then advance the clock, and avoid anything that does not change your plan. Now the core strategy, which works on almost every question. First, read the last line before anything else. It tells you what is truly being asked, whether the next best step, the most appropriate test, or the best initial treatment. Once you know the target, return to the stem, and you will stop drowning in detail. Second, anchor on the setting. A stable patient in your clinic points toward outpatient care, while the same complaint in the emergency department can change the right answer. Let us map the most tested concepts. First, outpatient medicine. Expect heavy testing on high blood pressure, diabetes, high cholesterol, thyroid disease, and preventive screening. Know when to start therapy, how to adjust it, and which screening is due by age. Second, acute care. Know the first moves for chest pain, stroke, sepsis, and the unstable patient. Third, do not neglect the foundations. Biostatistics, patient safety, and ethics are consistently tested and very learnable. Let us work through our first practice question. A 55-year-old man comes to your clinic with chest tightness on brisk walking that resolves after a few minutes of rest. He has high blood pressure and high cholesterol. His vital signs are normal, he is comfortable, his office heart tracing is normal, and he can walk on a treadmill. The question asks for the most appropriate next step. Notice the setting and how stable he is. Read the options, pick your answer, and we will reason through it next. Let us break this down. First, spot the pattern. Stable, predictable chest pain with effort that resolves with rest in a patient with cardiac risk factors and a normal office tracing is stable angina, not an emergency. Second, apply the rule. For a stable patient who can exercise with a normal baseline tracing, the cost-effective next step is an exercise treadmill stress test. Choice A, urgent angiography, is overkill. Choice C is not the standard first step. Choice D dismisses a real concern. The answer is choice B. Here is our second practice question, testing a high-yield protocol. A 72-year-old woman with high blood pressure and diabetes is found to have atrial fibrillation on a routine visit. She is comfortable, her heart rate is well controlled, she has no history of bleeding, and her kidney function is normal. The question asks for the best next step to reduce her stroke risk. The key is to estimate her stroke risk, then match therapy to it. Read the choices, pick your answer, and we will walk through the reasoning next. Let us reason through it. First, score the risk. Older age, high blood pressure, diabetes, and female sex all add points, and she scores high enough that blood thinning clearly outweighs her bleeding risk, so she needs true anticoagulation, not aspirin. Second, choose the drug. For most patients with normal kidney function, a direct oral anticoagulant is preferred. Choice A, aspirin, is too weak. Choice C delays protection. Choice D treats rate and rhythm, not stroke risk. The answer is choice B. Here is a quick reference sheet for outpatient pearls. When the patient has normal vital signs, no red flags, and reliable follow-up, keep them in the clinic and favor the simplest useful test first. Be suspicious of any choice that admits a stable patient or orders advanced imaging without a clear reason, because doing too much loses points as often as doing too little. And manage the whole patient. When two answers are both reasonable, the better one often addresses prevention. Now, a quick reference sheet for drug dosing and protocols. The exam rarely wants an exact dose. It wants the right first-line drug, the right adjustment, and the right monitoring. No first-line therapy for high blood pressure, diabetes, and heart failure, and which lab value to follow after you start or change a medication. Then memorize the classic protocols, including time targets for stroke and heart attack, fluids and early antibiotics for sepsis, blood sugar emergencies, and anticoagulation for atrial fibrillation. When a protocol has a clock, the timing is usually the tested point. Here is our third practice question, rewarding the whole patient mindset. A 60-year-old woman with type 2 diabetes comes in for routine follow-up. She feels well, her blood sugar control is at goal on metformin, and her exam is unremarkable. The one detail that should jump out is that she has not had her eyes checked in 2 years. The question asks for the most appropriate next step. Think about what preventive care is due and avoid a choice that does too much. Pick your answer, and we will reason through it next. Let us break down this answer. First, spot the screening gap. This stable patient at goal on metformin has not had her eyes checked in 2 years. A yearly dilated eye examination is part of routine diabetes care, so referring her is the preventive care that is actually due. Now the distractors. Choice B, advanced heart artery imaging, is the overkill trap with no cardiac symptoms. Choice C, admitting a well patient, is inappropriate. Choice D, switching to insulin, makes no sense when control is at goal. The answer is choice A. Here is one more quick reference sheet on cost-effective testing. First, reach for the cheapest useful test. When choices range from a focused history to a basic test to advanced imaging, pick the simplest test that meaningfully changes management and save the expensive scan for later. Second, match the test to the risk. A low-risk patient does not need an aggressive workup, and a high-risk patient should not be reassured and sent home. Third, beware the overkill answer. The impressive full-body scan usually does more than the patient needs. Let us talk about time management, because this is a 2-day marathon and pacing is where strong test takers lose points. There are 480 questions across 2 days, with the first day carrying more, each broken into timed blocks. That gives you a little over 1 minute per question. Know the clock and practice at that speed until it feels automatic, and learn to flag and move on. If a question stalls you for more than about 90 seconds, lock in your best guess, flag it, and move forward. Here is the exam day pearl that ties the pacing advice together, the 2-pass strategy. On your first pass, answer every straightforward question and commit to it. For anything that makes you hesitate, choose your best option, flag it, and keep moving, so you reach the end of the block with everything answered. Then, on your second pass, return only to the flagged questions. Resist the urge to second-guess answers you felt confident about. Change an answer only when you find concrete evidence you misread the stem. That wraps up our high-yield Step 3 review. Read every vignette like a physician deciding what to do next, and start with the last line. Lean into outpatient management, appropriate testing, and cost-effective care, and stay alert for the answer that does more than the patient needs. Know your high-yield concepts and classic protocols, and protect your time with smart pacing and the 2-pass strategy. Visit roadmaptoresidency.com for our expert tutors and residency advisors. If this helped, please like and subscribe, and we will see you next time.